We have now, what I want to do is open it up for more questions that I am going to ask that came from you, those wonderful 150 questions from you. And please, panelists, if there's anything that you want to interject at any time, we would just love to hear from you. But I'm going to direct the questions specifically to one of you, and then you can all jump in after they're done. And that, Stephen, I'm going to start with Dr. Madama. Because seems to be a real common question that I think it would be nice if we have a real clear understanding. What are the differences between hospice, palliative care, and home health care? How do you know when it's time to use each type of care? Okay? Very good question. Thank you. Pull it closer to you, maybe. No.
Oh, there we go. Okay.
There you go.
So I'm going to start off with home health care, and I will say that I'm not an expert in that specifically compared to other people that are here today. There are several home health agencies here, and so we can certainly ask them. But from a physician standpoint, whenever there seems to be a need for care that's not in the hospital, it's not provided in a clinic, but I feel that there is an extra level of care that's needed, typically physical therapy, but it can be occupational therapy, it could be some sort of nursing need. Then we look to getting home health care. And I think most people are probably aware in this room, but maybe some aren't, but I think more people have gotten educated over the last 10 years or so that, you know, home health isn't custodial care. It isn't somebody coming in and necessarily being able to give a bath or to be there all day long with someone who needs that kind of care. It does require what we call skilled care, so at the level of a nurse, a registered nurse, or a physical therapist or an occupational therapist. So when I see a need that the patient has some disability, they've had an acute event, typically, coming out of the hospital, you're probably aware that home health is used quite frequently for that transition from the hospital back to home or to the living facility where they reside. There's a requirement for physicians now, and well, it's for the patients too, and that is that we need to either have seen the patient 3 months before initiation or 1 month after initiation of home care, and that has to be a face-to-face visit. We also have a wonderful form now that we have to fill out that says, and one of the things is you need to be homebound. You have to, and really it's not a very high bar for most of the patients that legitimately need that. Of course, there's a lot of fraud and abuse that the government has found, and so then all of us who are doing things legitimately suffer with extra forms, but it's actually a pretty easy form to fill out to prove that somebody is homebound. But that means that it would be a great, either a danger or it'd be very inconvenient for somebody to go out of the home to receive that care. You can still go to the grocery store, you can still make doctor's visits, you can still, it's not like you have to be locked in your home. So those are some of the requirements that have to be met. And like I had said earlier, it's one of the ways when we know somebody's struggling at home, they're either not taking their medications right, their physical function is declining, we can usually get a health home care assessment to make sure it's appropriate and then get those services in there. So that's home health. Hospice and palliative care I'm sort of going to talk about in the same breath because they sort of developed together. Hospice really came on board in the United States in the 70s. A very small group of people started that, and it's grown over time. And hospice definitely is for people near the end of life or have a life-threatening illness, and is purely, directed at relieving suffering in those times. But I think there's been interesting studies with hospice recently, and I can't remember which kind of cancer it was, but there was a study in the last year where they divided people into getting hospice care and then sort of getting the usual care for a particular cancer. And the hospice care folks actually did have a better quality of life, which was not surprising, but actually lived longer, which is not the goal of hospice, but lived longer than the usual care. So I think that says something about, again, our typical medical model and how we go about things and sort of the revolution of hospice. Palliative care, I think, is a very interesting area, and I think that's probably the one that people are least likely to know what is palliative care. And when I look at the definition of palliative care, which is the prevention and relief of suffering, I go, well, isn't that what I'm doing? Isn't that what doctors should be doing? But it did come out of the hospice movement where there was a focus on symptoms. And the relief of symptoms, and not necessarily to try to cure disease or to prolong life. And so I think we're seeing, again, we've got a transformation in medicine going on right now, and I think we're starting to see evolution of palliative care into the chronic care model more and more now. It started mainly in the hospital. At St. Luke's, for instance, we've had a palliative care service, I think, for about 3 years, and we would use it for folks that got sort of an acute exacerbation of a chronic illness. They were not doing well, and we needed to just make sure we could relieve their suffering. We also used it as sort of a bridge, so to speak, to hospice. So patient and the family they weren't quite ready to say they wanted hospice services, but we'd sort of sneak in on them with palliative care and give them the care that they really wanted, which was relief of their suffering, and then they would see what those services were like and make them look at hospice a little differently. But I think now we're starting to have palliative care in the outpatient arena. I actually made a consult to our palliative care service on an ambulatory basis, which means outside the hospital. And I think we're going to see more and more of that, where we're trying to deal with chronic disease and acute exacerbations and focus more on the symptoms rather than, we know we're not going to cure the disease, but how can we better take care of it? So I think that describes those areas.
Excellent. Thank you so much.
May I ask Steve a question?
You may.
So what can hospice and palliative care do for the family caregiver? How can they work with the family caregiver?
Well, again, I'd probably defer to Mary Lou and some other experts that are in the room, but I know that there are services that hospice is able to provide. They're not available through regular Medicare per se, and so I just know that there are programs for the family to help take care. And I'd have to be honest, I don't know as much about those as I should.
I'm sorry I asked you that question, but so you all can speak with the hospice organizations and the home health care organizations that are here, because they can help you as well.
I know that that's a large part of the hospice care, is to help the caregiver provide the care they need to their loved ones. So.
Yeah, that's great. That's what you can. No apologies.
As far as respite, I do know that they can allow for 5 days stay in a facility. And I asked at the last Medicare workshop or training, how often is that limited? And they said it was unlimited, but when I had him call his main office to find out what that meant, they didn't say. So I don't know what that means, but they did. It's probably more than once in a year to have that 5 days through hospice.
I don't think people take advantage of that enough. That's a sad thing.
Yeah.
You know, it's in assisted living, and that's a really key issue, and that may be a way for caregivers to be supported.
We need to put it on a microphone, Steph.
Mary was just saying that people don't take advantage of that benefit often enough. They don't understand it. And that's something that the Area Agency on Aging could help people understand, or get them to resources where they could learn about it.
I think as an industry, we need to be doing a better job in educating everybody what it means to be on hospice, that whole piece, because really this is all about the holistic movement. This is all about being good to yourself and good to your loved ones.
Right.
We don't do a good enough job.
Well, and that's what the conference is about, and is getting the conversations going, and that's what Friends in Action is all about. We're all about the conversations for care. So let's move on to, if I may, are you okay? All right. So kind of going on with this, I'm going to ask a question to Donna, because it really is part of the start of this, is how do I plan for the costs of caring for someone at home? To even, being able to make these decisions. Where can I find help in covering the cost of care? For instance, does insurance cover the cost of my care? Does Medicare cover the cost of home care? What do I do?
Well, Joni offered some resources for you to look into what Medicare covers, what Medicaid covers, and what other programs cover. You know, I have, working with the elderly is my life work, and I have worked in many other capacities other than being an elder law attorney in the past 20 years. And I can tell you that as an attorney, probably about once a month, I will have an older couple come into my office, and they are absolutely devastated financially from the prospect of paying for long-term care costs. And they want to know, what can we do? How do we plan? The operative word is plan. Sometimes clients come to see me when it is past the planning stage, and they are actually now needing financial resources to pay for the costs of long-term care. As far as planning goes, there is long-term care insurance. I am hearing now from clients that it is getting ever more difficult to qualify for long-term care policies. There are fewer and fewer insurance agencies that are willing to issue long-term care insurance. I believe that there are some other financial tools, financial programs through insurance companies and so forth that are trying to assist with anticipating the costs of long-term care. With regard to Medicaid, Medicare does not cover long-term care costs, and that's one of the first things that I have to tell clients. Medicare does not cover long-term care costs. Medicaid does cover long-term care costs. They are the #1 insurer and financer of long-term care costs in the United States. It is a program that is designed for those who have depleted their resources, and you know, the public policy behind Medicaid is that we cannot, as a society in the United States, have our sick, infirmed, you know, elderly women on our sidewalks. And this is a safety net that our government provides for those who are basically indigent, so that they aren't on our street corners. You do have to be asset and income and need-based qualified for the Medicaid program. And I only have another minute here or so, but I just want to say that there is a program called the Federal Spousal Impoverishment Act for married couples, and it's designed so that a spouse who is the caregiver and living in the community does not have to become impoverished in order for the sick spouse to qualify for Medicaid program and Medicaid assistance. So I literally could talk for 3 hours on Medicaid and you would still have questions, but the long and short of that's the long and short of it.
Thank you. Appreciate that. Thank you. Yeah.